Okay, welcome to Unit 3, guys. Here's your video lectures for the Unit 3 Patho. So this unit basically contains kind of three big ones here, Chapter 17, Chapter 12, and Chapter 14. So we're covering GI disorders in the GI tract. We're covering the heart, cardiac disorders, and we're covering the nervous system and neuro disorders. So that's a lot. It's a lot of big stuff. I posted some links to some helpful refresh some YouTube channels that I really like for anatomy and physiology review. So if you're someone that's feeling really still uncomfortable with these systems and the basic A&P of how these systems work, we'll discuss that some, but just keep in mind, guys, you really got to have the basic A&P down to put all this together more effectively, especially for exams. And so I encourage you to check out some other resources that I posted or anything else, and some of the patho stuff that NAS has, the nursing resource we have. NAS has some great patho videos as well. I would just kind of absorb as much content, make sure you're comfortable with A&P. That's going to be the most helpful. So we're going forward. So the digestive system, small A&P review. You have upper GI tract, lower GI tract, and then you also have some of these accessory organs. So the accessory organs that I'm talking about mainly here is liver, pancreas. The liver has a little brother called the gallbladder. So liver, gallbladder, and pancreas are kind of known as accessory organs. The rest of this is known as part of the digestive tract, TRACT here, because it's basically where food goes. Food doesn't go into your liver, it doesn't go into your pancreas or gallbladder, but they are hugely important in playing a role in digestion, and we need them for digestion. So that's why they fit in the GI tract, and that's why they're called like accessory organs, because food doesn't go past through them. And that's what the tract's for. So functions, it's really just two, guys. It breaks down to two. It is it's gonna process food by digestion. So all digestion means is taking food and breaking it down into the smallest components so we can utilize it. So those components are only three. There's only three things that make up all the food we eat. It's either going to be protein, fat, or carbs. Now, protein, fat, and carbs all have smaller chemical components that we actually utilize, and you have to kind of have a general idea of that. And that breaks, protein is technically made of amino acids, fats is made up of different kinds of lipids, and carbs are made up, or sugars made up of different saccharides. Basically, these are the molecular structure of them at the smallest scale. So just keep in mind, and we're talking about digestion, we're talking about turning food into those three things: proteins, fats, and carbs. And then the other thing that our digestive system does for us is absorb those nutrients somehow, get those nutrients from the food, out of the food, into the bloodstream, processed, utilized by our cells, utilized by different organs. That's the goal. So again, break them down into their individual units. This process is usually controlled by mechanical movement of our digestive tract and enzymes that are designed to help break down these chemicals, or break down these things chemically. And then again, absorbs is about, we have specific membranes that help transport this stuff. And most absorption takes place in the small intestine. Most absorption. Digestion kind of continues throughout. So here's the anatomy of the whole digestive tract. Again, going through it quickly. As soon as food hits your mouth, you are now starting digestion. When food hits your mouth, you're chewing it. That's mechanical digestion, maceration with your teeth and your tongue. That chewing is mechanical. And at the same time, chemical digestion takes place because our mouth has saliva. Saliva contains a couple digestive enzymes that start to break food down. We swallow that. Using saliva makes it kind of gum up and solidify into like a liquid ball we call a food bolus. It passes through a muscular tube called the esophagus, all the way down through our diaphragm into our stomach. And then the stomach even does more mechanical digestion and a ton of chemical digestion, because the stomach's full of hydrochloric acid, a very corrosive, low pH acidic acid. It's a pure acid, basically. That, along with a enzyme called pepsin that focuses on breaking down protein. And the stomach actually is a very big muscular sac that does some churning. It churns and does some mixing, basically, of our digestive juice, or what we just ate. and slowly kind of breaks it down chemically with the acid. And then along the way, after it passes the stomach, goes into what's the first part of our small intestine here, called the duodenum or duodenum, however you want to pronounce it. I kind of go with duodenum. I kind of say both. The duodenum is the first part of our small intestine, and this is actually where most digestion takes place because our liver makes bile and our pancreas makes digestive enzymes for all three of the major components of food: protein, fat, and carbs, to help break all those down. Dumps all their stuff into the duodenum. That's where like the final hurrah of digestion of breaking food down takes place. And then we move into the second part of our small intestine called the jejunum here, that coils around, and that's where most absorption takes place. Now, digestion's mainly done, and we're working on absorbing these nutrients and put them into the bloodstream. Also, the last segment of our small intestine is known as the ileum. Here, the ileum is still focused on absorption. The ileum is what connects to the large intestine, and the large intestine is this kind of picture frame that frames out the small intestine. The large intestine and small intestine are named based on their diameter, not their length. We have like almost 18 feet, or I think it's 21 foot of small intestines, and somewhere in the neighborhood of just a couple feet of large intestines. They're named on their diameter, how big around they are. So the large intestine, when we're here, it's also broken down in several parts. This is the AMP. You have the cecum, which is the first part of the small intestine. Also has a little pigtail called the appendix, which is not a useless part of our intestine. It actually houses a lot of white blood cells and is part of our lymphatic system. Then our stool, or what's left of this food bolus, when it's in the stomach, it gets pronounced chyme. Once chyme's moving up, it's turning into feces now because we're reabsorbing electrolytes and fluid out of what's left. And mostly the large intestine is focused on fluid and electrolyte reabsorption, not absorption of nutrients. At that point, most nutrients are gone. We're just trying to get what electrolytes we can out of it and pull the fluid back out of it to form stool. So we go up the ascending colon, transverse colon, descending colon. We do a little sweep and head posterior towards the back of our body, posterior side, called the sigmoid colon here, kind of named because it does a little bit of an S shape. Rectum, and then at that point we're at the anus, the exit out to the toilet. Structures. There's basically 4 layers of our digestive tract. The wall of our gut, including our esophagus, stomach, all the intestines, is a mucosa. Mucosa is the most interior layer of our digestive organs. This is basically epithelium with these large mucus producing cells called goblet cells. Goblet, Goblet. Goblet cells produce the mucus, and they're important for. So I'm saying that mucosa, the cells that produce the mucus, are known as goblet cells. That is need to know. Goblet cells produce mucus. The layer underneath that's called submucosa, connective tissue, blood vessels, nerves, lymphatic vessels, glands, the stuff we would think of normally. Then we have a thick layer of smooth muscle around all of our GI tract, and they kind of help compress and move and do that mechanical digestion and keep food and stool moving through our lower GI tract. On the outside of our GI tract, we have a layer called the serosa, which is just a visceral peritoneum. It's a thin layer of a kind of membrane that surrounds all of our organs. So upper GI tract structures, really you can kind of go into, that's the oral cavity, the esophagus. You could say stomach. Stomach's misspelled here, I just realized. Yeah. Also, you could say the pharynx, the back of the throat. The throat itself would be kind of considered upper GI because food has to pass through there. Oral cavity, this is again when digestion starts, it starts in the mouth. We have mastication, excuse me, mastication by the teeth. The teeth mechanically break stuff up. And we have saliva that contains amylase and lipase that starts to break things down chemically, especially carbs. And this forms the food bolus, this kind of like slodge together, softened food with wet from saliva. Then we swallow it through the pharynx, back of our throat, and then hopefully it should head to the esophagus. We learned about aspiration. in chapter 13, and this is a case where this could happen if you have that weakened muscle called that muscular connective tissue flap called the epiglottis. It's supposed to slide over the trachea and let food pass through the pharynx to the esophagus. So kind of keep that in mind. The epiglottis is part of the larynx, technically, at the top, most superior portion of the larynx, but it folds over that larynx and tube to the trachea and lets food slide over it to the esophagus. Because the esophagus, we have two tubes in our neck. Trachea is on the most anterior side, and on the posterior side of our neck is the esophagus. So esophagus is generally kind of closed unless we're swallowing, because we're always kind of moving air more importantly than moving food. And this is a smooth muscle action and the action of the epiglottis. And the esophagus is pretty self-explanatory. It's just a 10-inch smooth muscular tube that allows food to pass through it. When we get to the stomach, the esophagus passes through our diaphragm. That's the main muscle that helps breathing, but it also is the main divider between our thoracic cavity and our abdominal cavity. And the stomach is a really expansive, just muscular sac. It acts as a reservoir for food, but it also churns it and mixes it because of these 3 layers of smooth muscle it has. So churning and mixing food, digestion by hydrochloric acid combination, and by an enzyme called pepsin that focuses on protein. Also, kind of keep in mind pernicious anemia, that anemia that's associated with lacking vitamin B12. The mucosa of our stomach produce something called intrinsic factor, and that helps us absorb vitamin B12 in the ileum. This is where we form chyme, CHYME. Again, it's not food anymore. It's changed. So that when they first talk about food after we swallow it, it goes through the esophagus. We're calling it a food bolus. Now in the stomach, it changes even more chemically, and it can't really call it a food bolus anymore because it's not going to resemble food, and it's not really food. So they call it chyme, CHYME. Some people pronounce this chime because that is how it's spelled, in fairness, but its correct pronunciation is chyme. And we do a little bit of absorption of the stomach, but the stomach is still mostly 100% focused on digestion. So take a trail over and we'll talk about the accessory organs. Liver. Think of the liver as a metabolic factory. It does a lot of stuff, right? Think of all the liver functions. It helps us. It's mainly a lot about ingesting these nutrients from the stomach or from our GI system when they get absorbed and trying to process them correctly. So it can store nutrients, plays a huge role in blood sugar homeostasis, carbohydrate management, helps manufacture proteins, helps metabolize fat. It makes our plasma proteins and clotting factors, which are essential for plasma proteins, are essential for that osmotic pressure in our blood vessels. Clotting factors essential for coagulation, right? It also is this organ plus the spleen are key components to help us break down old red blood cells, which we need to do. The other big thing it does for us, that's the GI related component, besides just the transport and storage and processing of vitamins, minerals, and nutrients, is it creates bile. Bile is a product that's goal is to help what's called emulsify fat. That word gets thrown around sometimes, and just in case you've never heard that defined before, the word is emulsify. Or let's say the process is emulsification. This is what bile does. That's made synthesized by the liver. Liver makes bile emulsifies fat. And so just to summarize that, in case you don't know what that means, think about fat. If you've ever had a pork chop or something like that, where you get a piece of fat in your mouth and you start chewing on it, it's really chewy and kind of gross. It's hard to chew. You don't even really want to swallow it. Fat lipids, that chemical that fat turns into on the lowest molecular scale, is still important for a lot of what we do. We need all 3 of those guys. We need protein, we need fat, and we need carbs. So fat, we need to break it down. So our body has created the liver having a job of making bile, and bile is this corrosive material that helps us absorb fat by emulsifying it. It basically takes large fat droplets, and bile comes in and helps to break them down by turning them into these little small fat droplets, basically. so that we can easily have other chemicals break them down. When there are big clumps, think about chewing the fat on a pork chop, it's hard to do anything with. So emulsification is this process of turning big pieces of fat into little pieces that are easier to manage. Again, that's A&P, but hopefully that helps kind of, if you hear the word emulsify, that's the role of bile. Doesn't really chemically break down fat into lipids, but it's helping to get us there. And this slide's not here, but the other little brother, I call it the little brother of the liver, is the gallbladder. The gallbladder is that sac that kind of hangs out with the liver. And the only job, and I'll go back to the picture, the only job of the gallbladder is to bile made by the liver. It stores bile. It stores it. So the only job of the gallbladder is to store bile for release when we get a meal that comes in the duodenum, comes in the duodenum from the stomach. And then it releases. When it stores the bile in there, it kind of helps concentrate it, make the bile more potent, basically. That's the only job of the gallbladder. It's the storage sac for bile and helps kind of make it a little bit more concentrated. So going back to that. So that's the role kind of the liver plays in the GI, is about the bile and fat breakdown, along with all the metabolism and processing of vitamins it does. The other big accessory organ is the pancreas. Some of you might know what the other pancreas role is. The pancreas plays a role in the endocrine system, secreting the two main hormones that help us regulate glucose. That's its main role in the endocrine system. But when we're talking about the GI system, we're actually talking about this. We're talking about its exocrine functions. Endocrine, if no one's ever said this, endocrine means to secrete into bloodstream. Exocrine glands secrete things into duct systems, series of tubes that then go somewhere else. So the pancreas is the only organ we have that acts in both worlds. It can secrete stuff directly in the bloodstream related to our management of glucose levels in the blood. And then it has an exocrine functionality, which is the GI functionality. Its functionality is to secrete digestive enzymes that help us break down. And this plus the bile from the liver all mixed together in one spot. That's in that first segment of the small intestine called the duodenum. And then most digestive processes take place here. Most digestion takes place here because of all the combination of bile, and the pancreas is the unique one that makes a specific enzyme for all three components of food, for protein, breaking down lipids, and carbs. It can help us do all. It has enzymes for all three. So again, you can see where knowing the A&P is very, very helpful here. So lower intestine, again, first section is the duodenum. Then we go jejunum and ileum. Jejunum and ileum are all about absorbing this material. Note that the duodenum is the site of most digestive process because of that combination of bile from the liver and pancreatic enzymes flow into the duodenum. So other things to note about the lower GI tract, especially the small intestine. The small intestine has these ridges or folds in the lining, so the tube's not smooth and straight. The tubes that make up our small intestine kind of have these mountainous regions to them. These ridges they call villi. And villi are part of that mucosa layer, these folds, and on the cells too. The cells on these microvilli, these cells in here even have what they call microvilli on them. What's the purpose of this? To increase surface area for absorption. Our body is a perfect machine at not wasting stuff. So as food makes its way through the small intestines, it's going to slowly slide into a valley and have to slide back out of it. As it does that, it has all these little microscopic areas that increase the amount of surface area, amount of contact with food. Therefore, we absorb more nutrients that way. There's also some in part of our small intestine, there's also some of these nodes that are they're like lymph nodes, and they're part of our lymphatic system called Peyer's patches. That our goal is mainly to monitor bacteria levels in the GI tract. So we'll talk more about that. But our GI tract throughout, especially in the large intestine, has normal flora, has normal bacteria in it. And that's okay. They're in lower levels, and it's kind of a symbiotic relationship. Normal flora in our GI tract actually help us break down food better because they tend to use things we will get rid of and waste as energy. And so they don't utilize all the things we utilize for energy. A lot of the bacteria use the waste products that we don't want. And so it's kind of this relationship where the bacteria get the food they want, but also help us keep breaking stuff down chemically. And it benefits us because they're not going after the same resources we are, like the proteins, fats, and carbs are going after acids and ammonia and things that we want to waste. So large intestine, again, much more the spot of the normal flora. There is breakdown of food, but the main goal of the lower GI tract is fluid and electrolyte reabsorption. We're turning this liquid waste that is chyme, and we're turning it into feces, into stool. And how we do that is we typically reabsorb all the water out of it. Again, body doesn't waste anything. Reabsorb the water out of it and continue on basically forming stool that way as everything compresses down. So again, digestion, absorption, got to know these three. Carbs, we see this in the small intestine, digestion in the duodenum. We see this start in the mouth. Proteins, we mainly see start in the stomach and in the small intestine because the duodenum, pancreatic juices. Lipids kind of mostly get broken down in the small intestine by the enzymes of the pancreas and the bile. The emulsification done by the bile that's made by the liver. So let's move, kind of shift our focus. That's the summary of digestive system and the A and P and how stuff functions. So let's talk about the disease processes, right? So general common manifestations you see with any GI system disorders is nausea, vomiting. Anorexia is a term for a condition where someone's not eating because of a mental health disorder, but it's also just a term that means no appetite, not eating. So anorexia doesn't necessarily mean the condition, it just means someone's not hungry, they're not eating. Bulimia is the condition where someone's having emesis on purpose, but anorexia is not. Other common stuff, these: diarrhea, constipation, abdominal cramps and pain, malnutrition, and then obviously, especially because our large intestine plays a decent role in fluid and electrolyte maintenance, that imbalances could happen definitely in the cases of diarrhea. For sure, diarrhea, you can always think of fluid and electrolyte imbalances kind of following that. So talking about diarrhea, the definition really of diarrhea is excessive frequency, which means number of stools, and they usually tend to be loose and watery, meaning that they've made their way through the large intestine too fast to have that appropriate water reabsorption. There are some conditions that cause chronic diarrhea, but it could be acute from your stomach bug, your viral infection. It could be nausea and vomiting associated with this, and definitely cramping, abdominal pain. And then again, diarrhea by itself is not too bad, but prolonged is going to lead to the dehydration, electrolyte imbalances, maybe even acidosis. Because remember, with acidosis, give you a second to think about it. What do we absorb in our GI tract? What's one of the components that deals with acids and bases that we get from our GI system, that we get from our food? I'll give you a second to think about it. I should have asked this question. I don't have a woo clap question for this. You answered. If you thought bicarb, you're right. HCO3. Bicarb is something we get mostly from our food. So to maintain acid base balance, diarrhea equals we're losing bicarb. So that's not good. Things that you don't necessarily want to see in your stool. Blood is definitely up there on top of the list. As far as things you don't want to see, just like we talked about things you don't want to see or shouldn't see in urine. You shouldn't see blood in stools. Blood can occur with diarrhea and constipation, but typically it's indicating something. Possibly they have tumor development, inflammatory condition. We'll talk about Crohn's and ulcerative colitis. IBS. Those are kind of things that can cause blood. And there's kind of always a frank versus occult blood. So frank bleeding means like bright red, you can see it. This is usually always something that's lower in the GI tract. When someone uses the word frank, especially in healthcare, we're talking about something obvious or something very blatant. So frank blood is saying like bright red blood, like you see it when you wipe. That could also be uh, linked to hemorrhoids, the broken kind of clumped blood vessels that appear around the anus from pressure of pushing too hard when trying to just defecate. Occult blood is basically saying that the stool looks normal to the eye, but when you test it, there's trace amounts of blood in it. And this could be from a condition kind of anywhere in the GI tract, much more insidious symptoms, maybe. That's more of a look into. Frank blood, usually we can kind of figure out, easily explain that. But occult blood is saying there's something going on that's maybe further up the GI tract. Um, One of the other main conditions with this is diarrhea, and again, most diarrhea and constipation most of the time are secondary problems to a primary issue, right? But they can be related to some acute and chronic conditions in our GI world here. But basically all constipation means is diarrhea was too many bowel movements. Constipation means too few bowel movements than normal, and everybody's normal is different depending on diet, exercise, age, lifestyle. But if there is constipation, you can still be constipated if you are stooling, if they're really hard stools. It means they've stayed too long in the large intestine and too much water has been reabsorbed, right? Maybe there's several reasons constipation can happen. It can be a chronic condition. It can be because of decreased peristalsis. So peristalsis, to go back to anatomy, peristalsis here is a term that is talking about the wave-like movement that our GI tract does. Our small and large intestine do this kind of wave-like movement with their muscle contractions, and that kind of helps propel the stool or the food bolus forward along the track. If peristalsis kind of slows down, basically the bowel's not doing this wave-like quivering motion. It's very like this. Then this stool is going to delay its movement, and that's going to be more potential for more fluid to get absorbed. Hard stools to not move at all, cause complete bowel obstruction, blocking it. Think of decreased peristalsis as muscular disorders, but also geriatrics, older age. Everything slows down. Metabolism, especially smooth muscle and skeletal muscle function, all slow down the older we get. And so constipation is a common concern for your geriatric population, for sure. Very, very common. Some of the causes, again, think weak, smooth muscle. Again, geriatrics, a muscular disorder. Not enough fiber. Fiber is a component that just basically kind of helps keep the form of stool. If we're dehydrated, that's not going to help with the fluid balance, right? Because we're going to hold more fluid anyway, and their stool will never be, too much fluid will get reabsorbed. Issues with incontinence of stool, immobility is going to slow this down. Some drugs, especially opiates, narcotics, they tend to have a side effect of decreased peristalsis and constipation. And then obstructions or things that clog up the GI tract cause constipation. So you want to make sure some of these causes of constipation, have a general idea. Because if I gave you a patient scenario, like well, let's look at the question. Sorry. So here's a question for you. Which intervention should the nurse prioritize? So we're talking about prioritization. We may do all these things, but what will we prioritize for clients that's experiencing chronic constipation? Give you a second to answer. And if you chose number 3, you're correct. The more fluid we do for them, the less likely their stools are to become hard and not move. Fiber is helpful for basically keeping stools form so it doesn't clog up, keeping its consistency. Fiber, think of just an ability to keep stools consistency is mostly what we use fiber for. Encouraging low fiber diet is going to make stooling worse. Regular laxative is not something you want to get dependent on. Use of laxative should be PRN or intermittent. It shouldn't be something that's chronically used. if we can avoid it. It depends. Some people just need Miralax. They need some form of assistance with defecating, but we want to try to avoid that at first. So it wouldn't be a priority. And then prescribing pain relievers didn't say anything about pain. They sure could be in pain, but that's definitely not going to help their constipation, right? So, nutrition wise or malnutrition, malnutrition is a condition where just limited nutritional intake, like we just have a limited number of those proteins, fats, and carbs. Um, Specific problems that are associated with malnutrition: vitamin B12 deficiency, iron deficiency. So you can think of malnutrition having a direct link to anemia, just because of we need iron, we need B12, and folic acid is another component we need to help us create erythrocytes, create red blood cells. So malnutrition and anemia are closely related. And general malnutrition could be acute disease, vomiting, acute diarrhea, chronic anorexia. But there's other conditions that could affect it. If I have a cancer or cachexia, the wasting syndrome with cancer, that could lead to malnutrition. They also probably have fatigue and anorexia. And then some of the chronic inflammatory bowel disorders can lead to issues with malnutrition. So some basic diagnostic tests. A lot of with the GI system is going to be about imaging, whether with the advanced technology, ultrasounds, X-rays, MRIs, CT scans, or with the old school archaic way of putting your eyes on something. So think of, we can do imaging, but we can also do fiber optic scopes. We can do scopes. We can send a small tube with a camera so a physical doctor can like visualize areas of the GI system and kind of get definitive diagnosis. You're going to see this more definitely with cancer diagnosis. They're going to want to visualize, take a sample, send it to pathology, but they're going to want to visualize it. So one of the differences with the GI system is there's not too many blood tests that tell us a lot with the GI system compared to some of our other body systems. Only thing that really tells us a lot about GI symptoms, they're very non-specific. They can be very non-specific. And so a lot of what GI diagnostics is, we need images. We need to visualize it, whether that's through, again, like CT scans or MRIs, advanced imaging, or with our eyes, to kind of put symptoms with physical limitations. With endoscopy, that would be up the upper GI tract, looking the esophagus and stomach. A colonoscopy, that's going from the other end, looking at the large intestine as far as we can see, looking for inflammation, bleeding, looking for cancer, that sort of stuff. The best, there's not too many blood tests. The best other test besides actually either imaging a GI system or looking at it with eyes would be stool samples. Stool samples can tell us a lot. Again, occult blood, what's in stool, what's not in somebody's stool, consistency, color, bacteria amounts. That tells us a lot about somebody's stool. And there's a lot of conditions like C. diff and some other stuff that we need a stool sample to really confirm a diagnosis without doing the invasive, putting our eyes on it with the scope. So, talk about some of the upper GI tract disorders. We'll talk about some of the accessory disorders, and we'll also talk about lower GI tract disorders. So, these are kind of all of them: disorders of our oral cavity, dysphagia, that's trouble swallowing, cancers, hiatal hernia, GERD, gastritis, peptic ulcers, gastric ulcers or stress ulcers, dumping syndrome, pyloric stenosis. These are some of the common ones, but we'll focus on a few here, and I'll try to give you the big need to know ones. Okay, so focus on when I say need. When I say need, you say, okay. Just try to come up with a rhyme, and I didn't do it. We'll see who watched the video lecture. How far are we in? I don't know. At the timestamp where I pulled up the slide about disorders of the oral cavity, let's see who could tell me the joke or the rhyme I tried to make that didn't happen. I might be losing my mind, guys. Hang in there with me. So, oral cavity infections. One of the most common ones you'll hear about often is called candidiasis or candidiasis. Candidiasis. Golly, I always have trouble with candidiasis. Candidiasis is a infection that most people, the easy name for it is thrush. Candidiasis is known as thrush. What thrush is that we have normal flora in our mouth, just like everywhere else, bacteria, and some fungi. And one of the fungi, Candida albicans, hangs out in our mouth if we have antibiotics. So usually you see thrush after a recent therapy with antibiotics. Sometimes those antibiotics kill off the good bacteria and allows Candida to the yeast, basically it's a fungi, to start to grow and colonize, and it has no competition now, so it grows, and that's where you get thrush, and it causes ulcerations and white patchy areas and red really swollen areas. It's pretty rough. That's candiditis in the mouth. I have to treat it with an antifungal. Usually you'll see this post antibiotic therapy. Another infection that we see sometimes related to the oral cavity is herpes simplex type 1, HSV1. Um, this is kind of this is usually transmitted by swapping spit, basically. You can alleviate some of this with antiviral medication. The biggest thing for this is not letting it spread anywhere else than the mouth. You don't want it to spread to eyes or anything like that. That can be a very deadly. Other disorders of the mouth, gingivitis. We all kind of heard of gingivitis. At least I have. If you have bad teeth and you've been to the dentist a lot, like I have. But gingivi is basically the name for your gums. So gingivitis is a local inflammation of the gums. So usually this is related to bad oral hygiene, uh, other genetic history of sensitive gums, and trauma from brushing too hard, and trauma from uh, ineffective cleaning, poor oral hygiene. So dysphagia is always something you want to keep in mind. Very similar to aspiration. Aspiration just means that someone has dysphagia, possibly. As all aspiration meant was that something ended up in someone's lung. Dysphagia just says someone has difficulty swallowing, which is a common condition associated with aspiration, especially in the geriatric. But all dysphagia means, the word is issues swallowing. Phasia means to eat, and the dys just means dysfunction, basically. It's how I look at the dys anything. So dysfunctional says that I'm not functioning properly. So if I have dysphagia, and phasia means swallowing, it means that my swallowing is dysfunctional. Dysphagia, I'm not swallowing properly. Typical causes for dysphagia are usually related to either muscular problems and older age, or neurological deficits that are affecting muscle as well. Um, so people with dysphagia can have pain, have trouble swallowing larger pieces of food, have trouble even swallowing liquids. And you'll notice this if a patient has dysphagia, they'll have like a cough, like all the time while they're trying to eat, and that just shows their gag reflex is not effective, and they have some form of dysphagia. So again, very common in people with stroke or brain damage, kind of that lower esophageal, or not, not LES, the epiglottis tends to kind of fail. And again, definitely going to see this with any muscular disorder like muscular dystrophy or other ones like that. Maybe MS, multiple sclerosis, something like that. It could be related to mechanical obstruction, something they call a stricture or a stenosis of the esophagus. So esophagus becomes tight and smaller, and the muscles aren't allowing things to go down smoothly. There could also be esophageal tumor. That's rare, but it does happen, and it's blocking it. So they're kind of showing these scar tissue and fibrosis kind of squeezes the esophagus. I could have a tumor squeezing it. Could even have a diverticulum, which is related to diverticulitis, another condition. I think the biggest take home point for you guys with dysphagia is it's very, very common. The need to know is it's very what it is, dysphagia. How would you define it? And then it's common in older adults, and it's due to the weakening of the epiglottis, or just the weakening of the esophagus in general. So think of it as generalized muscle weakness, and age is a risk. So let's see what you do with this kind of question here. So, I mean, I am assisting a client with dysphagia during meals. What nursing action is most appropriate? This one's kind of obvious once you actually read all the answers. Okay. If you answer number 4, you're correct. Serving food at room temperature does not change anything about dysphagia. Eating too fat, eating dysphagia, you need to be slow and precise with eating. So eating rapidly, not a good idea. And limiting oral care before meals is not going to really help anything. If anything, the better their teeth and their mouth are, the better off they'll be with chewing and swallowing. So the correct answer is number 4. One thing to note with this is just that with dysphagic patients who have trouble swallowing, they should be sitting upright, can't be laying in bed to eat. That's not going to help them. And one thing that always taught me with speech therapy when they talk about this sort of stuff is that think about the anatomy for a second. This is a nice to know, a little bit of a rabbit trail. So not a test question, but a nice to know is that remember the anatomy kind of your neck, right? You have like someone's neck, the tube in the front here, that's the trachea. Tube in the back, that's the esophagus. Remember, the trachea has the epiglottis that kind of folds over to allow food to get to the esophagus. There's your epiglottis. So if I want someone to have better effort in swallowing, look at the anatomy of this. If I tell them that what the speech therapy used to tell me was have a patient put their, when they go to swallow, put their chin. So like here's their neck and then their chin. That's a big chin. Anyway, you get the gist. Put their chin towards their chest because you can see what this does is kind of close down the trachea and make this a little bit wider of a hole for food to get down to. If I were to try and swallow something and I put my chin back, it kind of compresses the esophagus and opens the airway more likely. And that's why you'll see too, when someone's going to intubate someone or trying to help them breathe, and we teach with CPR, you kind of put you put the C technique. You put your thumb under their, and I don't know why I'm doing this. You guys can't see me, but you put your thumb under their chin and you pull their head back. That's compressing the esophagus and trying to open the trachea. So when you think about dysphagia patients and helping them, again, this is a nice to know. Think chin to chest for swallowing. So another need to know. This is a need to know, everybody. This is a need to know. Need to know is hiatal hernias. What is a hiatal hernia? Well, the hiatus is the opening in the diaphragm. So the hiatus is a opening the diaphragm. That's where the tube that runs also to the is the same. It's an opening in the diaphragm also that allows the aorta to run from the heart into the abdominal cavity. But it also is the tube where the esophagus comes from. So the esophagus runs from my neck all the way down to my abdominal cavity. Well, it has to pass through the diaphragm, and there's a little hole in the diaphragm that allows it through. That's called a hiatus. So the aorta and the esophagus pass through the hiatus. So what a hiatal hernia is part of the stomach has now protruded up and through the diaphragm into the thoracic cavity. There's several variations of hiatal hernias. There's a sliding hernia, which is more common. Portions of the stomach go slide up in the diaphragm. There's also rolling, which is part of the more lateral section of the stomach called the fundus, moves up through a weakened hiatus in the diaphragm and then gets trapped and stuck there. Sometimes the sliding one will go in and out with breathing, especially in changes in pressure in the thoracic cavity. It kind of depends, but overall, let's just talk about what someone's going to see with this. So with a hiatal hernia, the problem is food could get lodged there and not make its way through the rest of the GI tract. And that's going to cause a lot of inflammation, possibly infection around the esophagus and around the part of the stomach that might be involved. And they're going to have a lot of heartburn, frequent belching, a lot of gas in the upper GI tract. They're going to have really frank discomfort when they lay down and more substernal pain. So right underneath the sternum. So think about central substernal pain, feelings of burning, like heartburn, frequent belching. These are the signs of hiatal hernias. The risk factors are weakness of the diaphragm, obviously. But typically this is kind of related to increased abdominal pressure from obesity and weight gain or potentially pregnancy. Again, the symptoms are going to lead to kind of GERD symptoms, gastroesophageal reflux disorder symptoms. We'll talk about that next. and just general inflammation of the stomach and the esophagus, which could lead to ulcers or damaged blood vessels and bleeding. Hiatal hernia can be dangerous, and so we may need to fix it surgically. So, I mean, treatment a lot of times for people could be lifestyle modifications, losing weight. Typically, does this avoid laying back on the recliner or laying down after eating, treat the kind of reflux and heartburn symptoms, and potentially, if it's extreme cases, or not extreme, but potentially could be surgical intervention to fix it. So, out of what we just talked about, what's a symptom that's characteristic of a hiatal hernia? See if you can get this right answer. If you answered number three, you're right. The substernal, so right underneath the sternum, chest pain. So central chest pain, that's worse when they lie down. So GERD, what is GERD? This often comes with hiatal hernia. Again, they're kind of usually people don't have GERD, that they don't have a hiatal hernia, but if I have a hiatal hernia, it's probably going to cause GERD. But GERD itself just stands for gastroesophageal reflux disorder. This is also need to know, comes with the hiatal hernia. So these two are need to know for your tests and for your future. But basically, what GERD is a summary is just periodic reflex of the gastric contents, which remember is mostly hydrochloric acid into the esophagus, the distal part. This is going to cause erosion of the esophageal mucosa and chronic inflammation and pain and maybe even bleeding, because the mucosa is a lot thicker in the stomach because it's made to be, because that's where the acid is supposed to be. If the acid gets in the esophagus, the mucosa of the esophagus is not as thick and as well prepared for acid. So it's not ready for that. It usually causes inflammation and pain. Severity depends on, again, how bad the reflux is, can be variable symptoms. Um, Delayed. So some of the reasons this could happen is someone has delayed gastric emptying, which means that their stomach is delayed in emptying for some reason. Um, it could be related to medications that increase acidity and make reflux worse, or foods that increase acidity. So things that people have GERD with, what they have to avoid is usually caffeine, spicy or fatty foods, alcohol, smoking, and certain drugs can make it worse. So if I got I'm caring for a client with GERD, what dietary modification should the nurse recommend? We'll see if you can get there from what I just talked about. What do you think sounds the best for someone with GERD, with this reflux back into their esophagus? If you answer number three, it's that. So for a lot of people, they recommend, instead of doing the big 3 meals a day, right? Let's cut that down to like 5 or 6 smaller meals a day. Small, frequent meals will help digest food better, help with delayed gastric emptying. Some people can have GERD where they have a defective LES, a lower esophageal sphincter. That's the sphincter. Basically a sphincter is a band of muscle that comes into the stomach that helps kind of regulate flow from the esophagus into the stomach. And we have another sphincter on the distal end of the stomach called the pyloric sphincter, that its job is to kind of regulate flow out. And so someone could have delayed emptying of their stomach content. So small, frequent meals is good. We wouldn't recommend carbonated beverages, more acid. Wouldn't recommend more caffeine, spicy foods, no, that sort of stuff. One point to note, this is kind of a rabbit trail, but the book does talk about it. One of the most common normal flora we have is E. coli, Escherichia coli. I always just rather say E. coli than saying the whole thing, but E. coli is a usually harmless, normal resident in our entire GI tract. Just like um, they don't usually cause problems, but this is one of those opportunistic infections. This is also why it's not normally found in urine. Urine is sterile. So E. coli gets in urine. This is the most common bacteria to cause urinary tract infections. It comes from stool. That's where it hangs out. So just keep E. coli in the back of your mind. So working our way through disorders, we've talked about um, reflux and hiatal hernia. Another need to know here is peptic ulcers. Peptic ulcer is just a general blanket statement to talk about all kind of stomach ulcers, but peptic ulcers can be gastric or duodenal, meaning in the duodenum themselves. And what is an ulcer? Well, if you kind of think back, chapter 8 talks about different skin lesions, variations in skin injuries. And so ulcer is just a depression, an erosion of lining of an organ, in this case, the GI tract, whatever. That's all an ulcer is. So the normal lining gets eroded away. So when we have gastric ulcers, we're talking about the stomach is what gastric means. The stomach ulcers mean that mucosa that's nice and thick that secretes hydrochloric acid and secretes mucus. Um, the goblet cells create mucus in the stomach that gets eroded away, and now we don't have that protection, and the lining of the stomach starts to um, get inflamed and burn and maybe cause ulcerations to layers of tissue get destroyed. One of the main culprits, the main point to take away from peptic ulcers is this bacterium that's highlighted at the very start here. Most peptic ulcers, they have contributed to this bacteria called Helicobacter pylori, or H. pylori for short, which is much easier. H. pylori, Helicobacter pylori. The etiology of this guy is actually not totally known. We know that it's linked to causing ulcers because every time we see someone with some kind of gastric or duodenal ulcer, there's higher colonization rates, higher incidence of Helicobacter pylori. So we know it's a normal flora that can survive in high acidic environments like our stomach, and typically doesn't cause problems. But when it does, we can always tell that it's in higher numbers. So maybe whatever the cause is, we can link it back to high numbers of H. pylori. As soon as we see, so it's like an anecdotal thing scientists have said, well, when we find gastric ulcers, we tend to find elevated colonization of H. pylori. So we can treat this bacteria, and they know, and we've found out through research, when we treat H. pylori, we kill some of it off, we decrease its numbers, then we typically kind of heal their problem with ulcers. So it kind of, again, depends on where it's at. But just think of what ulcers are as basically the development is breaking down that mucosal barrier. Because think about the stomach again, hydrochloric acid has big epithelial cells that are big and thick and produce mucus. Well, that mucus is just that mucus in the GI tract is really, really important. It mainly acts like a slimy sludge that allows stuff to slide through our GI tract, which is good. But in the stomach, its mucus plays a big role because it offers a slimy layer of protection against the acid. And if that gets eroded away, along with maybe some of the mucosal cells themselves, the goblet cells, then we have free range for acid to just cause inflammation and actual damage. It basically inflames and erodes the mucosal wall. And that can lead to some bad things for sure. That's what a stomach ulcer is. So this is kind of showing you some common locations. That's not too big to know, but just know they can be gastric, they can be esophageal ulcers, and they can be in the duodenum as well. And the reason they call them peptic ulcers is basically the increase of the enzyme pepsin and increased acid production. There's a lot of things that they note are increased with these. But there's also some foods that there's certain foods that increase acidity, spicy foods, all that kind of stuff. But ulcers are definitely associated with a lot of caffeine intake, a lot of alcohol intake. This messes with the normal production of pepsin and other things in our stomach, and that's a contributing factor to ulcers. So what are the complications? So if you want to think about anything with peptic ulcers, one need to know is just what is an ulcer? It's an erosion of the mucosal lining. Why does it happen? Well, we know H. pylori is a very, very common implication in this. So if you want to say the main cause for peptic ulcers, treat it to H. pylori, the bacteria we find in our normal GI tract, especially in the stomach and the duodenum. And then what's the complications? Well, bleeding, hemorrhage, blood loss is a problem. This can lead to anemia, and you would find that occult blood in the stool kind of telling us there's a problem early in the beginning of the digestive tract here somewhere. It could erode all the way through the wall of the stomach or the duodenum. That's called perforation. Perforation means that there's been a hole or some kind of injury that goes through the entire bowel. And that's bad because that means that stomach contents or other bowel contents are leaking now into the abdominal cavity. That's scary. And it could potentially cause an obstruction later because of scar tissue development and that sort of stuff. So, hemorrhage, perforation, potential obstruction later. The pain, the signs and symptoms, manifestations for a person that's going to complain about is they're going to complain very similar, probably to GERD and that feeling of indigestion, heartburn, substernal pain. But usually it's going to, for them, peptic ulcer is the one thing that helps you say the need to know for peptic ulcers and pain is the one variation that's different than like traditional GERD pain is that you're going to have GERD pain very shortly after eating. For peptic ulcer patients, they tend to have pain at night, and pain is actually relieved by ingesting food or antacids. But so food digestion actually helps the pain. That's unique about peptic ulcers. It's when the stomach's completely empty and there's nothing else in there except acid. Then and then we tend to have more pain. So it's usually a pain at night with peptic ulcers. So that's the interesting thing. Another side note: stress ulcers. These are predominantly the same thing as peptic ulcers. They're just H. pylori is not the common factor with this. This is commonly related to PTSD, emotional trauma, life stress. And the difference with these is peptic ulcers tend to be a much more gradual process, rapid onset with stress ulcers. Usually in the gastric, and it usually happens hours. So I have a death in the family. Hours later, I get an ulcer. And usually they'll have very severe pain, very similar pain symptoms for other peptic ulcers. It's relieved when they eat, but they're much more prone to hemorrhage. Dumping syndrome is another side note to make. So dumping syndrome is basically how we control gastric emptying, how we control stuff leaving our GI tract. If stuff is not properly broken down in the stomach further and then just kind of dumped in the duodenum without complete digestion, they call that basically hyperosmolar chyme. And it tends to basically, because it's so it hasn't been properly digested, it tends to like have an osmolarity that pulls fluid from blood vessels into the duodenum to try and like keep diluting this down because it hasn't been diluted down enough. So this can lead to fluid volume deficit, so like hypotension, tachycardia, weakness, dizziness. Could lead to confusion, hypoglycemia, diaphoresis, which is sweating, pallor. Typically, you're going to see this after someone's had a gastric bypass or gastric resection surgery. So dumping syndrome is something that's more associated with gastric bypass surgery. If you don't know what gastric bypass surgery is, there's different variations of gastric bypass, but basically it's making the stomach smaller and changing the way we digest food and to help lose weight, and very drastic surgery. And most of their problems are dumping syndrome. I've never really heard of one thing I'll say with gastric bypass, if you're someone that's larger, you're thinking about that as an option, I'm just telling you anecdotally from my experience in healthcare and as a nurse in med surg world that like I've never seen someone that had gastric bypass surgery that hasn't had any complications, honestly. um it does happen. There are people that are really smart about it and people that make good recoveries and lose a lot of weight, but just saying, I would try other methods before gastric bypass. So again, dumping syndrome is this occurrence where abdominal cramps, there's going to be nausea and diarrhea, and glucose levels tend to fluctuate. Sometimes it can resolve over time, but for them, the big correction they need to make is smaller, frequent meals, high in protein and low and simple carbs. And this is just kind of showing you dumping syndrome. is a chart in your book. It's a good chart, but just here, dumping syndrome, you're thinking about gastric sleeve, you're thinking about gastric bypass surgeries, and then problems with malnutrition, problems with acute regulation, and a fluid shift because of this dumping syndrome. So, disorders of the liver and the pancreas, the big guys, the liver, super, super big, important organ, pancreas up there as well. So, let's talk about it. Um, One other thing to note is you kind of include the gallbladder in this, right? So the gallbladder is basically just the little brother of the liver, like I said. And the only purpose of the gallbladder is to, um, the only purpose of the gallbladder is to hold bile for the liver that's made by the liver and release it when we get a meal that dumps into them to help us digest fat. So some of the conditions associated with the gallbladder, you need to know these. But chole, that chole, chole is just kind of this Greek word meaning like the bladder or the gallbladder. So chole means gallbladder, and then the rest of these words you've kind of seen before. You've seen lithiasis, that's stone formation. Remember that with kidneys. You've seen itis before, that's inflammation or infection. So cholelithiasis and cholecystitis are just inflammation, infection, or stone development. Again, the main function is to store and concentrate that bile made by the liver and then release it into the duodenum. So cholelithiasis is gallstones can develop. So they typically form in the bile ducts of the gallbladder or the cystic duct. So the ducts basically are those in the anatomy. The gallbladder has a cystic duct that leads to it, and it meets up with ducts that come from the liver. So the liver is always making bile. It's just sometimes some of that bile will make a stop and go hang out in the gallbladder while the liver still makes bile. So it's like, again, to have a storage repository of bile and to make it more concentrated. Typically, what bile is actually made of, bile is interesting. Remember, bile tries to emulsify fat. Bile is actually made up mostly lipids. Bile is made up of mostly pigments and cholesterol, which is in the family of lipids, and a mixture of some calcium salts. So when bile stones form, gallbladder stones, they're typically mostly made of cholesterol, actually, hardened cholesterol stones. And if they get wedged, they're going to obstruct the flow of bile. This is going to cause severe pain. It's going to cause the gallbladder to probably become inflamed. Some of the risk factors for gallstones is that for whatever reason, it seems that women are much more likely to develop them. If I have high cholesterol levels, obesity, use of oral contraceptives and estrogen for some reason tends to make a higher incidence of gallstones. If I have issues with my liver, it tends to have more potential for gallstone development or an infection around those in that area as well. So if that gallbladder gets a stone, we get cholelithiasis. I may be able to, the stones may leave the gallbladder, pass through the ducts, end up in the duodenum, and then out my stool, and I'm the wiser. If that happens, they may evaluate me, but typically what happens is those stones mess with the flow of bile enough that it causes cholecystitis. It causes inflammation of the ducts and inflammation of the gallbladder. And when that happens, it's going to be kind of a backup of bile into the liver, and it's going to cause a lot of pain, nausea and vomiting usually, and then potentially jaundice development. So let's talk about jaundice. I mentioned jaundice before. You need to know what jaundice is, but jaundice is because we talked about this with the blood chapter. Jaundice develops because a component the liver uses in bile called bilirubin comes from heme that we break down from hemoglobin or red blood cell breakdown, which our liver does that. Our liver breaks down the red blood cells. So our liver uses bilirubin to help us make this bile. If bile backs up because it's being obstructed by a gallstone, then bile will back up into the blood. And all bile really is a pigment. It's a yellowish brown pigment. And so whenever we get jaundice, it's basically a yellowing of the skin, nail beds, and the yellowing of the white part of our eye, the sclera. So when you hear yellowing skin, yellowing sclera, you know we're talking about jaundice. Now, don't stress too much about these stages, like when jaundice happens: prehepatic, intrahepatic, and posthepatic. This is just talking about where it happens. Just know what jaundice is. The need to know is just know what jaundice is. Know there's a potential problem either with the liver or the gallbladder or both, because there's bile backing up into my bloodstream and that's causing jaundice. But these just talk about what could cause it. Again, hemolytic anemias means over destruction of red blood cells, so therefore extra bilirubin. Intrahepatic means there's a disease of the liver itself, and posthepatic is talking about there's a gallbladder stone, there's a tumor, there's something blocking bile flow. And we measure bilirubin as direct or conjugated bilirubin, and we can measure that in blood. So we can measure bilirubin amount in the blood, and the higher the bilirubin, the more likely we have jaundice. So hepatitis. What is hepatitis? Well, hepatitis um, is just a word that means general inflammation or infection of the liver. So the liver is hepato. Hepato means liver. So hepatocyte is a liver cell. Okay. So hepatocyte is a liver cell. Hepatitis is just a general term to identify our liver. And so hepatitis is saying inflammation or infection of the liver. There's some reasons it could be inflamed or infected. Alcohol causes fat development in the liver. Idiopathic is also by fatty liver. Viral infections, we'll talk about those. Those are the hepatitis A, B, and C, D, E viruses. We have a series of viruses called hepatitis. But again, the term hepatitis just means general infection or inflammation. Infection somewhere else in the body or certain chemicals or drugs can affect it. So, like for example, the viral hepatitis or infection elsewhere in the body. The examples of these, just to give you some reference: infectious mononucleosis or ambibiosis. Does anyone know what infectious mononucleosis is? Blah. Infectious mononucleosis. You probably got it from these first three letters here, or four letters, excuse me. Mono. It's mono, the infection mono, or the quote unquote kissing disease. Mono is a virus that it's a form of the Epstein-Barr virus, and it's spread through saliva. So that's why they call it the kissing. It can be through kissing, but it could be from sharing a drinking glass or sharing food utensils with someone that has mono infection. So mono is known to cause a lot of systemic inflammatory effects. So it can actually cause hepatitis. And amebiosis is a parasite, basically. More common in people living in tropical areas, but it's a parasite that's known to cause liver and spleen enlargement. So those are interesting and rare. But just in case you didn't know what infectious mononucleosis was, or amebiosis, amebiosis is a parasite. Infectious mononucleosis. Once you see the mono, you know it's mono. So let's talk about the viral hepatitis. So hepatitis again is a condition just says inflammation or infection of the liver. Viral hepatitis is a series of different viruses that cause inflammation and death of liver cells, and it just varies degree. So again, there's five technically. There's A, B, C, D, and E. Basically, the hepatitis virus specifically targets only the hepatocytes, the liver cells, and damages them either directly, or it causes our cellular immune system to trigger a response against the virus, which, remember, viruses like to infect hosts. So then hepatocytes are destroyed that way. And a combination of two happens depending on the virus. So let's talk about these guys. You want to have some of these nailed down, but we can simplify it. Let's just talk about all of them. The big thing I want you to nail down for viral hepatitis, the need to know here. Are you listening? I know it's a long lecture, but the need to know here is just the differences in how these are transmitted. There's some specific stuff about them. I'll give it all to you that the book talks about, but how are they transmitted? Okay. So hepatitis A is known kind of as infectious hepatitis. Hepatitis A is transferred by the oral fecal route. Ew, right? What that means is either by infected food that's been prepared by somebody that maybe had hepatitis A and didn't wash their hands before preparing your food, infected shellfish, or infected water. This is not a chronic disease, doesn't have a carrier state. Hepatitis A, you get infected with it, it should run its course, you should be able to treat it, and you should be okay. You don't chronically carry it, you don't have it forever. Hepatitis B, the HBV. Hepatitis B is transferred by blood or body fluids. So you can remember hepatitis B is, this is stupid, but if you want to remember, hepatitis A comes from the fecal oral route. It means it's probably come from someone's stool. Hepatitis A for ass, ASS. How many instructors you know going to say that? But hepatitis A for ass, it came from gross poo. Hepatitis B is come from blood or body fluids with a B. The unique thing about hepatitis B is it's often asymptomatic for long periods of time. So this one sticks around and has a long incubation period. Hepatitis C is most commonly coming from blood only, blood transfusions. There's a high incidence of hepatitis C in IV drug users because of the sharing needles. There's also a risk associated with, not so much now because regulations are bad, but there's also a risk associated with like dirty needles for tattoos and that sort of stuff. Actually, my great aunt passed away from liver failure because of hepatitis C. She got from a dirty needle and a tattoo in the late 70s. So, yeah, I mean, it's possible. So, A, think of as fecal oral route. B, think of blood or body fluids, usually asymptomatic, long incubation period. Hepatitis C, usually very symptomatic, sticks around with you a long time. It's much more commonly seen in IV drug users. Hepatitis D and E. E is very similar to A. More common in certain African or Asian companies. Hepatitis D, as in Delta, requires the presence of usually hepatitis B together to thrive. So hepatitis D and E are less known. I would just kind of focus on A, B, and C. Those are the more common ones, and that'll help you kind of get them. So A for fecal oral route, B for blood, and is usually asymptomatic. C, very symptomatic. Blood, transfusions, or IV drug users, that sort of thing. And all of them are viruses that target hepatocytes. So signs and symptoms. Icteric, you see this word icteric, you don't necessarily have to know. Icteric means jaundice. If you want to get really technical, really technical, this word ICTERIC, icteric, the icteric, some people call it icteric, I call it icteric, just means jaundice. You want to get real technical about it. So like they're saying pre-jaundice, muscle pain, fatigue. Once jaundice sets in, stools get lighter in color because bilirubin's what makes her stool brown. Urine gets more bilirubin in it because they're trying to filter it from the blood. So urine gets darker. Liver swelling, pain associated with that. And then when recovery happens after like hepatitis, there'll be more weakness, but reduction of symptoms. So you don't necessarily have to know these, but if you just see icteric, I wanted you to see what that word meant, basically. And then finishing off, yeah. Typically for treatment of hepatitis, it's going to be diet that's high in carbs and protein, rest. For chronic hepatitis, mainly when you think of chronic hepatitis, you're thinking mainly of chronic. I think another way you can remember hepatitis, another way you can remember hepatitis C is that there's not really a cure for hepatitis C, and it's chronic. If that helps you remember hepatitis C differences. Remember, guys, there's so much information in patho and so much stuff you have to pull from A&P and in nursing in general, right? Remember the differences. So if I'm telling you now, you need to know the differences in how you can track hepatitis A, B, and C. Don't worry about how they're similar, right? Hepatitis B is blood, just like hepatitis C. But what makes hepatitis B different? Oh, it has long periods of asymptomaticness, and typically it's not chronic. Hepatitis A, not chronic. more like a really bad stomach bug with I get from fecal oral contaminated water or food and progresses. No chronic state. Hepatitis C is chronic, no cure, CC. We can treat symptoms, but sometimes it's just a virus that stays in the hepatocytes, and we just try to keep the viral replication down. There's a medication called interferon plus other antiviral drugs that seem to be the most effective. Interferon is only effective, though, around 30 to 40% of individuals, but we can treat chronic hepatitis with a drug called interferon. So know the hepatitis A, B, and C for sure. Just know there's a D and E, but those aren't as big. And know the differences between how you contract hepatitis A, B, and C. What our symptoms look like. And then for C, we can treat with interferon, know what interferon is, that sort of thing. Hang in there. We're keeping going. Cirrhosis of the liver. So liver cirrhosis is basically the word cirrhosis for liver. This is need to know, guys. This is need to know. Liver cirrhosis means progressive destruction of the liver. So what causes progressive destruction of the hepatocytes? One of the number one things, this is very similar to the conversation about COPD. We know that with COPD, it's very commonly related to smoking. Not always, but the most common cause of COPD is smoking. Same thing here. Liver cirrhosis is not always just alcoholism, but alcoholism is a main contributor to a lot of the cirrhosis cases. Not all of them, a few of them. Other things are immune disorders that mess with the duct work of the gallbladder and the liver. Also, chronic hepatitis that you may have got completely not of your own fault. You could have got a needle stick at work, God forbid, and got hepatitis C. That could cause cirrhosis. There's other genetic links to cirrhosis as well. But what happens with cirrhosis is we have trouble with this bilirubin regulation. We have less bile, which means we can't digest fat as well, right? So bad nutrient absorption because all of our nutrients, remember, anatomy wise, we have what's called the portal vein. All the veins that leave the GI tract make a portal, a trip over to the liver to get processed and toxins to get filtered. And we can't do that effectively. We don't make enough blood clotting factors, so blood clotting is affected. We have trouble storing glucose and regulating our glucose. So, and one other thing we do, our liver filters out toxins. One of the toxins we create from our normal cellular metabolism is ammonia. Now, we usually get rid of this in urine, but our liver has to convert this ammonia to something we can get rid of in urine. So if the liver's not working well, then ammonia doesn't get converted to something that can go in urine. And so ammonia levels will rise. So this kind of gives you a big chart. This is a chart from the book. So let's talk about the manifestations. What does it look like? Anorexia, weight loss, anemia, because red blood cell production, right? Abdominal pain of the right upper quadrant, because the liver's in our right upper quadrant. Later, you're going to see fluid shifts, so edema, something called ascites. We'll talk about ascites in a second. You're going to see esophageal varices. Varices is an ulceration and scar tissue development in the esophagus. And then jaundice, encephalopathy. Encephalopathy is basically confusion based on elevated ammonia levels. Because ammonia gets so high, just think of the liver. If it's failing, it affects almost everything. So your big stuff, liver fails, right? Blood, not able to blood clot, right? Anemia, right? Ammonia elevated equals I'm confused. Increased bilirubin, which equals icterus, right? Jaundice. Let's see. Unable to filter. This is the ammonia is related to unable to filter toxin filtration. I think that's the big ones. I think that's kind of where you want to put like what I'm thinking about with, because there's decreased red blood cell production. Oh, and probably hypoglycemia or glucose homeostasis problems. There's your other one. That's the big stuff. The liver does so many things, 250 plus tasks the liver does for us. It's a lot. This is just a chart to kind of show like all the things they could have if you want a nice thing in it. So you can see yellow, right? Confusion, the jaundice, edema shifts in the lungs or the skin, edema in the lining of the stomach. There's the ascites, the swollenness, the pain, bruising issues, because of the blood clotting issues, that sort of stuff. And this is a chart from the book in chapter 17, table 17.6, that kind of gives them all to you. They're not all need to know, but you want to have that general concept. You want to have a general concept of the manifestations you're going to see in a patient with cirrhosis. You've got to have it down. I think some of the big things is, again, anemia, fluid shift, blood clotting. And so with the fluid shift, you might get general edema, but you also might get this ascites here. Ascites means that the blood flow to the liver is hypertension, it's high, and fluid shifts, and fluid tends to shift with liver problems almost all the time. One of the most common symptoms is this ascites. This fluid accumulates in the space around the abdominal cavity called the peritoneum, the membrane around the whole abdominal cavity, cause the abdomen to swell, become inflamed, cause pain, excessive weight gain all of a sudden, that sort of thing. Pancreatitis. So pancreatitis, talking about the accessory organs still. Pancreatitis. Remember, all the pancreatic juices are important. Usually what happens with pancreatitis is that those pancreatic juices we use that help us absorb everything start to actually self-digest the pancreas. And the reason this happens could be multifactorial. Can be acute or chronic. Typically, a pancreatitis is a medical emergency, hospitalization, that sort of stuff. Pancreatitis can lead to destruction around surrounding tissues, but a lot of times with pancreatitis, whatever the cause is causing it's causing necrosis. It's causing tissue death to the pancreas, which is not good. There are you could get pancreatitis related to someone having peritonitis, which is inflammation, infection of the peritoneum. We'll talk about that, which could lead to sepsis. But typically with a pancreatitis, it could be related to gallstones as everything gets blocked up. Typically, again, kind of like liver cirrhosis, typically, even more than liver cirrhosis, this guy is associated with alcohol abuse. In my experience, anecdotal, again, anecdotal just means personal experience. I'm not basing this off of research. I'm basing this off my personal healthcare experience. Pancreatitis coincides with alcohol abuse a lot of times out of 10, I'll say. Okay. So with pancreatitis, the main thing they're going to have is the severe abdominal pain, severe abdominal pain. Their abdomen might be distended, kind of like ascites, and lose some bowel sounds, but they're going to have nausea, vomiting, low-grade fever, and severe abdominal pain. So your big nursing consideration with pancreatitis is the abdominal pain. We have some enzymes that we're looking for in the pancreas. So we're going to look for those enzymes, mainly amylase. We're going to see if amylase levels are elevated. And we're going to look into other stuff. If their white blood count's up, are they fighting infection? What's the cause of pancreatitis? Again, not always alcohol, but it is a lot of time. So we got to find the cause of it. But basically, if you're looking at diagnostic tests, the thing they're looking at a lot of times for pancreatitis is what's this amylase level, because the pancreas is basically digesting itself. So if this digestive enzyme is really elevated, that means the pancreas is digesting itself bad. This is a chart kind of from the book. You don't necessarily have to know about that, but this shows us what's kind of happening. So we're almost there. We're working through it. Lower GI tract disorders. So we're talking about the small intestine, large intestines, and the whole abdomen as a whole. So I'll go a little quicker. Celiac disease. This is a easy peasy one to talk about. Basically, celiac disease is a malabsorption syndrome. This is gluten intolerance. Gluten intolerance, the technical name for it is celiac disease. It basically is a defect in the intestinal lining that the enzyme that helps us break down the product known as gluten is ineffective. And so when we eat things that are high in gluten, we usually get symptoms of diarrhea or malabsorption with this. So uh, we diagnose this with a series of blood tests, and the treatment for celiac disease is a gluten-free diet. But typically, there's signs and symptoms with this is abdominal cramping, diarrhea, just GI upset when congesting foods that are high in gluten. So that's celiac disease. So Crohn's, we're going to talk about Crohn's and ulcerative colitis. The need to know is the difference between Crohn's and ulcerative colitis. The need to know is the difference between Crohn's and ulcerative colitis. Crohn's disease is part of these two guys that are a family of inflammatory bowel diseases. They are inflammatory bowel diseases. They're genetic in nature, but the complete etiology of Crohn's and ulcerative colitis are not fully known. So Crohn's disease, what makes it unique is if it can affect any. So again, no differences, find differences in things. Crohn's disease and ulcerative colitis can have very similar symptoms, guys. So know the differences. Know the differences, right? So Crohn's disease is going to affect any area of the digestive tract, lower GI tract, kind of anywhere, small intestine, large intestine, could work its way up towards the stomach, but it can affect anywhere. It has severe inflammation that makes these things they call them skip lesions, which are basically certain segments of the bowel are affected. Where there's initial inflammation, and then these thickened nodules develop, and it creates a cobblestone. So Crohn's, I always kind of remember Crohn's with a C equals cobblestone effect inside. So you think if someone's talking about cobblestoning or cobblestone appearance, they're talking about these skip lesions, these lesions that skip over random of parts. So they affect one part of the small intestine. That usually happens in the small intestine, but it can happen anywhere. Happens one part of the intestine, then skips somewhere else to another part of the intestine. This basically impairs the absorption of the small intestinal wall. That's its main problem, along with just the symptoms of inflammation. So interferes with absorption. So they're going to have malnutrition, have low protein potentially. Again, if the adhesion kind of in between certain parts of the bowel, it could erode through the lining of the bowel and cause fistulas or perforation of the bowel, that sort of stuff. Typically, Crohn's is associated with diarrhea. So typically, Crohn's is associated with diarrhea. Let me say it one more time, and I know it's a long lecture. Crohn's is associated with diarrhea. Okay. Crohn's is associated with diarrhea. So the other one that's in the family of inflammatory bowel diseases is ulcerative colitis. This is inflammation that mainly is around the rectum, the lower end of the large intestine. So ulcerative colitis is more around the rectum, but can be in any part of the colon. So where Crohn's is more any part of the intestine, but mostly in the small intestine, ulcerative colitis is only really either in the rectum or the large intestine, somewhere in the colon. Okay. And this comes with basically severe acute episodes with like acute exacerbations. So you got to need to know the difference between ulcerative colitis and Crohn's. Basically, what happens is the inflammation is so severe that the tissue becomes super edematous, super edema, and frail, and the tissue kind of gets damaged and ulcers develop. That's where the ulcerative colitis comes in. So again, ulcers, erosion of the tissue layer happens. And this interferes with absorption and electrolyte balance, because remember that our lower GI tract is all about fluid and electrolyte reabsorption. So ulcer colitis, they can have more systemic effects associated with fluid shifting or loss of fluid and electrolyte imbalances. It can have severe acute episodes with what's called toxic megacolon. If you want to know what toxic megacolon is, it's basically severe inflammation that totally just interferes with the normal movement, peristalsis, the wave-like movement. And this leads to possible blockage, a bowel obstruction. Other unique things with this is increased risk of cancer when you have ulcer colitis, and the diarrhea is even more than Crohn's, much more diarrhea, up to 12 stools per day. That's a lot. So more diarrhea, risk of megacolon, ulcers that form in the mucosa. Those are some of your differences. And here's a picture to kind of give you an idea. So normal colon here, ulcerative colitis here. You can see all the inflammation. So much inflammation. So much inflammation. That's probably might be some dead tissue there, some bleeding happening here. That's bad. That's bad. That's tough. So the nurse is educating the client newly diagnosed with inflammatory bowel disease. Which statement by the client indicates a need for further teaching regarding Crohn's? So which one of these is incorrect about Crohn's, right? This is asking you, you gave education to a client about their new diagnosis of Crohn's, and they tell you something that says, okay, they didn't get everything they need to know about Crohn's. I still need to do more teaching. So what tells you that? If you said number 2, you're correct, because this is talking about ulcerative colitis. You can experience fistulas, abscesses with both of the conditions. Patches of cobblestone tissue, the inflamed tissue throughout the digestive tract. You could. It's going to be kind of everywhere. Abdominal pain, diarrhea. Yes, that could be also Crohn's, but this is the main difference between the two is that ulcer colitis is more colon rectum. Crohn's could be anywhere. There's a difference. IBS is not inflammatory bowel, but irritable bowel is basically you either have IBS-D or IBS-C. IBS-D is based on your symptoms of diarrhea. IBS-C is based on constipation. This is more related again with diarrhea or constipation. The IBS is more in the family of diarrhea is the main symptom associated with the Crohn's and ulcerative colitis, the inflammatory bowels. Irritable bowel syndrome is more inclined to have a periods of constipation with periods of diarrhea, a mix of both. Okay. There's no single cure for IBS, but there are meds and there are treatments and lifestyle modifications, that sort of stuff. So continuing on, appendicitis. What is appendicitis? Appendicitis is inflammation of the appendix. You need to know what appendicitis is. Need to know. The appendix plays a role in our lymphatic and immune system, so it houses white blood cells. The problem with this is positioning. The appendix sits on the cecum, which is it's like a little tail. It's like a little dependent tail, basically, that sits here. There's our ileum that comes into the large intestine. There's our ascending colon going up. The appendix is here. This is a bad drawing, but you get the gist. And stuff flows through here as stool and things pass through here. The white blood cells are able to get trained, kind of do a check on stuff, kill any excess amount of bacteria. But sometimes stool or something will just get wedged and stuck in here. And then it will cause swelling and inflammation of the appendix, which is bad because it's not a big area. And if it swells too much or it could rupture and spill stool and GI contents into the abdominal cavity, which is bad. It depends. If a gallstone can make it down there, it just something blocks it up, and then the appendix is going to get inflamed and swollen. That's appendicitis. If the tissue dies and gets necrotic, then it just totally burst open and lead to a perforated bowel. And that's a lot of cleanup. This is a little bit weird word. This is the standard sign and symptom of appendicitis is this frank right lower quadrant pain, because that's where the appendix is. So frank right lower quadrant pain is the main, along with some nausea and vomiting and just general local tenderness to that area. This is the LRQ is just worded weird. I think that's just dyslexia taking over. Sorry, where's my mouse? Okay. So I'm assessing client suspected. I suspect this guy's got appendicitis, which is a classic symptom of acute appendicitis. Give you a hint, trying to go a little faster. I know it's been a long lecture. It's rebound tenderness at McBurney's point as the right lower quadrant. So rebound tenderness is if I push on the right lower quadrant and when I let go, it hurts. That is acute appendicitis. Typically, the swelling actually feels better when we compress it and we push on it. And then when I let go of it, the pain gets worse. That's a big deal. So the need to know is, where am I looking for pain with appendicitis and kind of what the risks are. If their bowel ruptures and spills contents, it's possible for them to get an infection in their peritoneum called peritonitis around their entire abdominal cavity, but also for it to get into their bloodstream. And it's really hard to clean someone out after this happens. And it's very risky. They're more likely to have septicemia, to get septic, to get bacteria or infection in their bloodstream. So that leads us to peritonitis, which is a need to know. Talked about ascites, which is fluid buildup in the lining around the abdominal cavity. Peritonitis is inflammation and or infection of the lining around the abdominal cavity called the peritoneum. So why this happens could be related to pancreatitis, again, a ruptured gallbladder, ruptured appendix, perforated ulcerative colitis ulcer, something like that. This kind of talks about its pathway, but I don't think this is too detailed for us. Just think of peritonitis as, again, some kind of trauma in the intestines, like a ruptured appendix, a bowel obstruction, a blockage in the bowel that causes the bowel to rupture and the bowel to die. It's bad news. Foreign material left in abdominal surgery, that would be very bad. And actually, PID, pelvic inflammatory disease in women, can actually, related to their fallopian tubes and inflammation there, can lead to peritonitis. Signs and symptoms is they're going to have generalized abdominal pain, not localized to one area. And their abdomen is probably going to be bloated and distended and tender, painful to touch, localized tenderness. And they could have some low blood pressure, hypovolemia. They could have some fluid shifts too, as fluid shifts into this peritoneum. So the need to know to think of for them is a firm, tight abdomen. So it's firm and really tight and distended, bloated out. And they have a lot of fluid shifts and manifestations of dehydration, like tachycardia, low blood pressure, and then really, really tender abdominal pain, that sort of stuff. And that wraps up chapter 17. It's a long one. I told you these 3 chapters are tough. So hang in there with me, guys. I'll catch you guys on the next one. Hope you have a great day.